So this is really the time, and we really have an opportunity here to make a substantial impact. I'm sure many students think of the work ahead and think of the papers that need to be written and the PhD thesis that needs to be put in. But certainly when I got to know Fariba and David, it wasn't about the papers or the theses. It was about actually making a very substantial impact and to alter the trajectory of children. And I'm delighted that we're going to hear a little bit about Leo Flynn shortly, which will give you a little bit of a human context for the whole story. And as many stories in the heart valve zone start, it's this very tedious comparison between a mechanical valve and we call it a tissue valve. It can be a stented bioprosthesis like this, or it can be a homograft, a donated valve. And this debate has kind of dominated everybody's thinking about heart valves. Which is better, which is superior, which has less reintervention rate, etc. But actually the problem is we're kind of stalled on this, and this debate is really distracting us from moving forward, because as many of you will know, it's not that the mechanical valve lasts forever, and it's not that anticoagulation is well tolerated necessarily in all people. And so we really need to also recognize that neither of these valve substitutes really do anything close to the job that a normal pulmonary valve would do. Yes, there are some improvements, and they're really, really important improvements. This is a valve called the Onyx valve, which is like a 4th generation mechanical valve. It's got nice technology for the pivots. The leaflets get beautifully washed. And it was noted in India when these valves were placed, where the children didn't take any anticoagulation at all, that actually the valve stayed working. And that led to a number of observations that actually patients with these devices could be run at a lower level of anticoagulation. And that is now coming into more routine practice in the Western world. The same valve in a tube as a valve and ascending aortic replacement is a very good solution for people who need an aortic valve and aortic reed replacement. Someone of my age might really benefit from this to give them 20 years worth of relatively trouble-free outcomes. The xenograft space, I mean, these tissue valves, they all involve animal tissue of some sort, with various treatments that have evolved from glutaraldehyde, incorporated some anti-calcification treatment, have evolved, but they haven't really substantially changed. And this is an issue. The good thing is that they're now delivered through a transvascular approach. And this is certainly a marked improvement. And they can even be used in larger outflows, as sometimes occurs in tetralogy of Fallot, where we've previously removed the valve and left a space which becomes very big over time. There are still operations which mostly done in the pediatric age range because they're so big and such intense technical exercises that are actually being shown to be useful in the adult world as well. This, of course, is not a new operation. This has been around for 4 decades or more. And in this beautiful no bleeding diagram, it shows the transfer of a pulmonary valve to the aortic space, replacing the diseased aortic valve, and placement of a pulmonary homograft, a donated valve, into the pulmonary position. And this is an operation that surgeons train for and get very nice results from. But the adult group have struggled with it because they don't do that kind of surgery routinely, whereas pediatric surgeons tend to do that more successfully. But there are some great insights from this approach. And the biggest insight was recently published, which shows a comparison of propensity matched individuals having the different sorts of valve replacements. This is mechanical and bioprosthetic valves in this trajectory. And this is normal survival and the patients who've had the Ross procedure. So the people who've had a ROS, despite having a huge operation, their outcomes actually mirror that of the normal population. Although this is big news, because so few things that we do return people to a trajectory of a normal population person. You'll notice that the time scale is out to around 15 years and that there is a few problems developing there. The ROS is not without its issues, but it's about the quality of the normal pulmonary valve, which as much as possible is what we seek to emulate. The advent of transvascular aortic valve replacement was a boon for people in their 70s and 80s who needed a valve because their aortic stenosis was making them have chest pain. They couldn't walk to the bathroom. They were essentially chair-bound individuals in nursing homes. It's all changed. Now this technology has expanded down to the middle age group where people of standard risk are now being considered eligible for this kind of approach. It's great that we can deliver a valve in this way, but the valves are just the same bioprostheses as we were talking about before. And so to truly get the leap that's required, we need to have a better valve to be able to implant using this technology. Mark is going to talk a little bit later about polymeric heart valves and his role in this story. But this is a very impressive valve which is coming through clinical trials at the moment. You can see the leaflets are not covered in fibrinous material, not covered in platelet deposits that might fly off and give the patient a stroke. These are very clean looking leaflets and inserted in the transvascular approach. And Matt has researched some really excellent stories as to the Australian and Scottish contributions to this technology. And the incredible story that great products can be out there, but if they're not funded, they never find clinical application. And so this is something that as clinicians, we need to be more aware of and more accepting of new things, even though the first outcomes may be problematic. We've been speaking about adults and children, but now I just want to focus on children because kids have that additional problem that they need to grow. And so whatever we put there needs to be able to cope with that issue. And it's also a problem because all the work that we have to do on the inside needs to be repeated to replace things that don't grow. And that's a very dramatic example of right ventricle to pulmonary artery conduit replacement, where the hood is right below the sternum and it's a real risk at re-entry for the next operation. And there is a difference in the products that are coming to market between people who need a tube in a valve, so a so-called conduit, versus just a valve in itself. So I just want to talk a little bit about tetralogy of Fallot. Leave the details aside. Most operations involve removal of the pulmonary valve, leaving a space there, free pulmonary regurgitation. The child grows up with apparently few symptoms, but gets to the point in adolescence or early adulthood where the right ventricle is huge. And if we leave it like that, over time, it reduces its ventricular performance. And that's a big problem because that ventricular performance never comes back. And so I think most people believe that it's important to replace a valve into this context to allow the ventricle to stop deteriorating. And ideally, if we did it soon enough, would stop any deterioration at all. Protecting the right ventricle is really important. I'm zooming forward to something which is just in investigational use at the moment, which may be a big change for people with this condition, with large outflows. And I do it because it beautifully combines the surgical approach and the interventional approach using inspiration from venous valves. So venous valves are long loopy things which accommodate the changes in size of the vein. You know, when you're in bed, the vein is small. When you're exercising, the vein is large as the cardiac output is increasing. And the vein valve, venous valve, remains competent despite, you know, those two circulatory states. And you can see here that the leaflets are long and they're reinforced by stent structures at either end. So there's only a few centers in the US that are implanting these at the moment, but there's a substantial bit of science behind it, which was published last year, I think. And you can see that over a range of 1 to 1.8 times, the valve retains its ability to prevent regurgitation, low regurgitant fractions in the 10% mark, and no important obstruction. And so this is a great novel application. It's the kind of thing actually we've talked about a lot in making long valves to improve competence as the child changes size. The problem is the material is just Gore-Tex. And Gore-Tex is great. It's been around for a long time. It's ePTFE to be precise. And surgeons have been making valves for the pulmonary position for some time. You know, look at this reference. This was a 10 to 15 years worth of work published in 2018. Really good results from handmade valves. These so-called bulging sinuses, emulating the normal situation where the leaflets get out of the way for the blood to flow through. It's good. This one was taken out about 1.5 years for other reasons. And you can see the leaflets still look thin and a little bit mobile. But you can see here what's happened after 10 or more years is the leaflets get trapped by the pseudointima, which is growing on them. And there's evidence of calcification and other things. So yes, the valve is great, but its limitation ultimately will be the Gore-Tex itself. Modifying ePTFE is a big thing, and we have a Gore-Tex expert in the room up here. I'm sure Steve might have something to say about this. But the way that the clinical Gore-Tex is provided is a multi-layered thing. There's like a skin on it that helps reduce the bleeding points as you stitch it, and that's great. This Gore-Tex is actually made as a single layer, and it's much more dense and it's not as nice to sew. But the nice thing about this is that it can be dilated. And so you can create a connection which, with a balloon dilatation on the inside of it, can be increased in size over time. And this is something that we have available to us in daily work. And this group is also producing a valve. The leaders in the Gore-Tex field, the Gore company from a while back, said, well, we can produce an RV to PA conduit. What's the fuss? And they did produce one. It was in a single size and it didn't work. They made some surface modifications. We don't know what they were. Maybe it was also the valve design. Don't really know what that was. But there was a significant incidence of thromboses of these conduits requiring replacement, which is pretty remarkable. And I think it also points to the fact that maybe Gore-Tex is not the future of our particular valve. So what of tissue engineering? We had this conversation earlier. It's a lovely concept. It would be beautiful to think that we could create a structure for autologous ingrowth and that structure would become your own and that it would grow with you. Perfect solution for children. But just as in adults, in children, the host response is different. And what works in a sheep, what works in person 1, 2, 3 might not work in person 4. And a failure rate of 25% is clearly unacceptable. And so we need to find a place for this technology. And it may be that the tube is an appropriate place, not the valve, because any thickening of the valve that's occurring as a part of the inflammatory response is unlikely to be effective in the longer term. In closing, I want to just point to the fact that the heart team, which used to just be the surgeons and the cardiologists, and then the imagers came in, and then we had the whole range of other people involved in that clinical process, really now needs to include the scientists and the engineers. And to have an understanding of what the strategy is and how we can get to a better place, we also need the parents involved, because they are advocating for their children, but they're also investing in a future which is better not just for their child, but also for future generations. And it's the parents that shift the politicians which make this work possible. And that is exactly what's happened in the context of this group. So together, we have to customize, we have to combine approaches, not be stuck to any particular strategy, and work on both materials and designs. The book is not shut on either of those. Leave you with a picture of the Cape of Good Hope. I hope that we are rounding it soon.